somebody makes a comment about, Aboriginal people leaving the emergency department because they couldn't be bothered to wait. And you just kind of want to bang your head up against a wall and be like, did you ever think that the emergency department might be the problem and not the Aboriginal person?
This is Listen, Learn, Respect, a podcast by the National Apology Foundation, coming to you from River City Studios in Meanjin, Brisbane, home of the Turrbal and Jagera people. My name is Jessica Rudd and I'm co-chair of the foundation. Outcome number one under the national agreement on closing the gap is Aboriginal and Torres Strait Islander people enjoy long and healthy lives. The target is to close the gap in life expectancy within a generation by 2031. Proud Yuin woman Natalie Bryant is a public policy researcher. She's currently a Sir Roland Wilson Pat Turner PhD scholar at the Australian National University, and she's investigating the absence of reforms to support Indigenous self-determination in the hospital system. Thank you so much for joining us on Listen, Learn, Respect, Natalie.
Thank you. It's a pleasure to be here.
Can you tell us a little bit about your background? Where did you grow up?
Sure. So, as you've already pointed out, I'm a Yuin woman. So Yuin is the nation that runs from about La Perouse all the way down to south of Eden on the south coast of New South Wales, so all along the coastline. And I grew up in Nowra, which is pretty much smack bang in the middle of that area. So I have an Aboriginal mother and a non-Indigenous father. And to be honest, I was raised as much by my mum as my uncles and my grandparents. And really fortunate, I actually got to know and spent a long time with my great-grandmother. So she was 100 when she passed away just over 10 years ago now. And she was one of the oldest elders on the south coast of New South Wales. So, that was pretty special for us. But yeah, so I grew up in Nowra and then eventually went to ANU for university, did my undergrad there, studied law, decided halfway through that I had absolutely no interest in being a lawyer and wanted to do, I actually wanted to do education policy, but somehow ended up in health policy. And that's pretty much where I've stayed now since I finished uni.
Well, it sounds like it's been an amazing choice for you. So what inspired that keen interest in health policy from the get-go?
I sort of have always seen there's to address the disadvantage in Indigenous population, we do die substantially younger than non-Indigenous peoples, my grandmother notwithstanding that, my great-grandmother, sorry. So I've always worked in mainstream. I've never worked in Indigenous health prior to doing this research. I've worked very much in mainstream roles doing, drug and alcohol treatment grants. Most recently, I worked for the Independent Health and Aged Care Pricing Authority, which is about public hospital funding and pricing. So, and just in that, I've always sort of tried as best as possible to advocate and to change, perceptions of Indigenous peoples in those roles. So I've worked across both state and Commonwealth as well. So which has sort of given me an opportunity to really understand our health system, I think more than your average Commonwealth public servant does.
And congratulations on being the Sir Roland Wilson Pat Turner Scholar at ANU. It's a huge achievement. Pat Turner, who's a board colleague of ours at the National Apology Foundation, is at the forefront of a lot of community efforts to close the gap in health outcomes.
Being a Sir Roland Wilson Pat Turner Scholar is an absolute honour and privilege, and it brings with it a lot of responsibility, I think. Auntie Pat is amazing and has done some amazing work in this space.
Can you sum up for us why Indigenous self-determination in the hospital system is critical?
What we know is that our hospitals are currently failing Indigenous people. There are some pockets of success in the hospitals, but, I think we only have to look back to see the coronial inquest into what happened at Domagee and see that our hospitals are failing my people.
The coroner today concluded that both Domagee Hospital and local health provider Gidgee Healing did not give adequate care, describing the system as broken and suffering systemic failings, including racism.
But we have this amazing example in the community-controlled sector of the Aboriginal Medical Services and Aboriginal community-controlled health organisations who are focused on social and cultural and emotional well-being of a community. They're not looking at people as a bunch of limbs and organs and diseases and illnesses. They're looking at a whole person, a whole family, a whole community. And they are good for Indigenous peoples. They have better outcomes. There's evidence out there that shows that there are lower levels of hospitalizations and there is a lower suicide rate where you have community control of health services. And we saw it in COVID. In New South Wales, the ACCHOs and the Aboriginal community mobilised rapidly. And that resulted in a really small number of COVID cases within New South Wales and no subsequent deaths up until December 2020. And that was local knowledges and solutions that were tailored to the local community. The Aboriginal community controlled services are culturally appropriate, they're comprehensive, and they're governed by and directly accountable to local communities. So we need to try and emulate that in the hospital space. We have this example. I think Megan Davis talks about, in one of her articles, she talks about how the ACCHOs are the embodiment of self-determination. But if you go into a hospital in Australia and you're Indigenous, you are less likely to receive the treatments you need. You're less likely to be put on a waiting list. Like if you have kidney disease, you're less likely to be put on a waiting list for a kidney transplant. So you'll be on dialysis for years. Once you're on the waiting list, you wait longer. Like we have evidence that supports this. And it's not just in kidney disease, it's in heart disease, it's in burns victims. And so we need to change the system. Like we can't keep doing the same thing over and over again and expect a different outcome. And so I guess tying that back to, target one, we have got no hope of closing the gap within a generation by 2031 if we keep going the way we're going. We need to look at the health system as a whole and not at primary care over here and go, yeah, primary care is doing great, but you can't have a baby in a primary care health service. If you break your leg and you need surgery, you can't do that in a primary care service. There are things that can only be done in a hospital, and we need to bring that self-determining mindset and those principles of self-determination and decision-making into the hospital space and change the way we run our hospitals, because Western biomedical models don't work. They don't work for most people.
Correct. Yes.
But they especially don't work for Indigenous peoples.
You've worked in systems at state and federal level. What would you change immediately about how health policy works for Indigenous people? If you had a magic wand, like I'm telling you right now, you've got a magic wand and you get to make the decisions, what would you change right now?
I'd make Arnie Pat the Secretary of the Department of Health. And then every DepSec underneath her, Aboriginal or Torres Strait Islander. I think that's part of it. It is about representation at senior levels. We've never had an Indigenous Secretary of the Department of Health. I don't think we've ever had an Indigenous Deputy Secretary. If you look at state government, we've not had an Indigenous Secretary of the Ministry of Health in New South Wales. So there is that. But bringing in perspectives at all levels, in all areas. So Indigenous health cannot be just managed by the First Nations Health Division or the Centre for Aboriginal Health. It can't be siloed into that. It has to be across every facet of government and every facet of decision making. And I'm pale-skinned, and people have said some of the most ridiculous things around me because they either don't know or don't care. I've heard, Aboriginal people, they don't wait like in emergency departments. That's the reason they discharge, or they don't wait for medical treatment, or this or that. And like, we are often blamed for the health problems, and there's that failure to recognise that it's far bigger and far more insidious. Institutional racism in this country is so embedded. It's normal. That is the life we live every day, and that's become more and more obvious as I've done this research. But it's also, I think, in the world we live in today, it's become more and more obvious in the political environment that we're in. People, I would wear my woven earrings, and that would maybe sometimes make people check themselves before they said something. This year, it somehow emboldens people to say the most racist and disgusting things around me. And I just find that is my experience. And it's not necessarily that people have poor intentions. I think it's just so ingrained in how we work. So I guess the other thing, don't want to give away the solution that my PhD is going to hopefully deliver, but we need to think about all policy and think about how all policy meets the needs of Aboriginal and Torres Strait Islander people, not just health policy, but, we've got housing, education. We have our First Nations ambassador, like looking at how foreign policy impacts Aboriginal and Torres Strait Islander people.
We tell a more powerful and more persuasive story of Australia when we tell our full story.
We need to look at that at every facet and look at how we can ensure that we're doing that, and not, it needs to be meaningful and authentic. And it can't just be ticking a box to say, oh yes, we've consulted with an Aboriginal person or a Torres Strait Islander person, but is it the right Aboriginal or Torres Strait Islander person? You know, what authority do they have? Do they have the cultural authority to be consulted, or are they just the poor APS 6 in the Department of Health who happens to also be Aboriginal?
What exactly is your PhD investigating?
So my research is really looking at how we can kind of emulate what's happened in the primary care space in the hospital setting. So I work in hospital funding and policy. So we determine the price that is paid by the Commonwealth for public hospital services, and that dictates the funding for a lot of services in states and territories. And I've always sort of found it really challenging to be in that space, because I just don't think there's face validity to a lot of how we fund our hospitals, in particular for Aboriginal and Torres Strait Islander peoples. And so when I first started applying for the scholarship, and I was looking at the Indigenous adjustment to the pricing model. So there is an Indigenous adjustment, which is about 4%, which is basically paid on the price for a patient who identifies as an Indigenous person. And it's one of a suite of adjustments that can be applied to the pricing model that reflect, you know, the legitimate and unavoidable variation in the costs of delivering healthcare. And so that had always bothered me, because I thought 4%, it's a drop in the bucket, but it also treats all Indigenous peoples as homogenous. We're not all the same. We are a multicultural people. And that really kind of just irked me. And then it also just doesn't consider the unmet health need or the underservicing of the Indigenous population that we know that happens in our hospital systems. So I started out there, and as I got deeper into it, and I realized that I didn't really want to just make a little difference. I wanted to make a big difference if I could, and playing around the edges of the Indigenous adjustment was just not going to work. And I was encouraged by my CEO and mentor to think bigger, and so I did. I went back to the National Health Reform Agreement and had a look at how Indigenous peoples were reflected in that.
How our plan is designed to make sure that Indigenous patients are given the care that they need, along with all other Australians.
And, you know, we're only referenced in there 3 times. You know, one is an unavoidable cost to the system, one where AHACPA must have regard to them in terms of adjusting the price, and then one which is just a list of responsibilities for funding services outside of the hospital system. And I was just like, well, that's frankly not good enough. And then that led me back to the National Health and Hospitals Reform Commission and the recommendation to establish a National Aboriginal and Torres Strait Islander Health Authority. It was proposed to operate the way Department of Veterans Affairs operates now in terms of purchasing hospital services for veterans. It was proposed that this do that for Indigenous peoples. But I think what bothered me more than anything else, it wasn't that the recommendation itself was rejected. It was the fact it was the only one that was rejected of 123. Everything else was accepted or noted. And if you think about the time, this was in 2010. And at the time, so we had in 2007, your dad, Kevin Rudd, was elected. 2008, first time ever, a welcome to country was done at Parliament. The second day of Parliament, the national apology to the stolen generations. And a year later, we had the Labor government endorse the United Nations Declaration on the Rights of Indigenous Peoples. So you have all of that happening on one hand, and then on the other hand, you had this recommendation and it was rejected. And I just couldn't let go of that. And so that's how I've ended up researching what I'm researching and looking at why we have this amazing self-determining, community-controlled primary healthcare system, but in a hospital system, we have very little Indigenous perspectives taken into account, and how can we learn from one and bring it into the other. I want to look at whether this recommendation was any good, I guess. Was it the right recommendation? If it was, then why was it not supported? If it wasn't, well, what was proposed instead of this? Because it sort of feels a bit like it could have been a game changer, but it may not have been.
So who do you talk to about that when you're researching it? Like, what kinds of people are you talking to?
So I'm sort of midway through my interviews at the moment. And so interviewing senior bureaucrats of the time, like people from within the system, Indigenous leaders, so people who played significant roles in NACCHO or in the National Indigenous Health Equity Council, people who worked in the community-controlled health sector at a state level, also looking at some of the politicians that were involved in these decisions, and health policy experts and members of the commission itself. So sort of hoping to interview about 30 people all up, like across those four spectrums.
You must have a sense in your innermost thoughts of what was going on at the time. Can you test against that hypothesis? Is that what you're doing, or are you kind of going really open-mindedly into the process?
Well, look, I'm trying to be open-minded, but, you know, I think, as you can imagine, we do have our gut feelings. And I do think I think it was such a radical proposal. And at the time, it was maybe too radical for where we were at in the world. I also...
Would it work now?
Maybe, but it would have to come from Indigenous people. It would have to be a recommendation. It would have to be a body that was supported and wanted by Indigenous people. And I think that's probably the other reason why it wasn't supported at the time, is that the National Health and Hospitals Reform Commission had no Indigenous members. They sought discussion papers from a variety of health policy experts, none of whom were Indigenous. And so that there was an absence of Indigenous voices in the process, and therefore there was sort of no Indigenous buy-in to it. And it's unclear whether, what level of consultation was done, but certainly there was nobody to advocate for it. And so it kind of, when I talk to people now and I say, oh, do you know about this body that was proposed? Oh, no, I don't really recall it. It almost petered out and it was never spoken of again. So until I came and started talking about it constantly over the last 2 years.
It's good. I'm glad you are. So you've worked in health reform and health policy for more than 10 years at Commonwealth and state level. What has that been like as a First Nations woman? You've spoken to entrenched racism that you experience around you every day, and that being deeply embedded and ingrained into an Australian way of thinking. Can you give me some of that from a work perspective? Would you be comfortable sharing that with me?
Look, I've always worked predominantly in mainstream areas. The only time I worked in an Indigenous space was back in 2006, 2007. And I was very grateful that I left a week after. I was leaving already, but I probably would have left regardless a week after the intervention was announced, which was it was very hard to be working in the Department of Health when that was the policy of the day.
Good evening. John Howard is sending special police squads to sweep through Aboriginal communities and arrest parents who abuse their children.
I've always worked in really supportive places. I'm often the only Aboriginal person, so become a bit of the Indigenous clearinghouse. But, where I work currently, there are 3 of us, which is great. We're still by far the minority, but 3 out of about 80 is not bad in a mainstream area. And so we work from within to try and chip away at some of those, ingrained misunderstandings of Aboriginal and Torres Strait Islander peoples, and looking at, why don't we have a board member who's Indigenous? Why don't we really have Indigenous representation on any of our committees? We've been working very hard in IHACPA over many years to embed cultural safety. And I think we've done that quite well under the guidance of our CEOs, and that continues under our new CEO. And I think with that, you're just sort of slowly changing people's minds a little bit, but it is hard. Like sometimes you just kind of want to bury your head in the sand a little bit. And that's kind of how I felt this year, to be honest. I have spoken about Indigenous voice to Parliament more than I would ever like to. I'm often the only Aboriginal person people know, so everybody wants to ask your opinion.
Yeah.
And it's exhausting and it's traumatic and it's really draining. And so that's probably my experience over the past 10 years. At times it's been really positive, and other times, like, you know, when somebody makes a comment about, you know, Aboriginal people leaving the emergency department because they couldn't be bothered to wait. And you just kind of want to bang your head up against a wall and be like, did you ever think that the emergency department might be the problem and not the Aboriginal person? And trying to, you know, show people the data and the evidence to say, actually, here's the problem, you know, not the Aboriginal person who's left. So look, just chipping away at it over the past 10 years and, you know, hopefully making a much bigger dent in it over the course of my PhD and what will come from that.
Oh, yeah, it'll make a splash. The National Agreement on Closing the Gap has been built around 4 priority reforms that have been directly informed by Aboriginal and Torres Strait Islander people. Priority Reform 3 is about transforming government organisations. What do our government organisations need to do to be more effective in responding directly to the needs of First Nations peoples and communities?
I think we need to find a language to talk about the problem of, you know, racism and the effects of colonisation, which are ongoing. We don't have that language in Australia. We don't talk about race, really. It's a discussion that's obviously been had this year, but we don't have a really good way of talking about it. And it's not about interpersonal racism. It's not about individuals or calling out like that sort of type of direct interpersonal racism. It's about understanding that our systems have been designed in a way which does not represent all people, and especially doesn't represent Indigenous peoples. I can't help but think back to one of the quotes that I heavily lean into and into my PhD is Chelsea Watergo. And speaking at the Lowitja Institute International Health and Wellbeing Conference in 2009, Chelsea talked about the need to consider how institution structures, systems and processes operate to undermine Indigenous health and wellbeing. And that's what we need to lean into with Priority Reform 3. We need to talk about what the problem is. We need to have an honest, open dialogue. And once we can have that honest, open dialogue, then we can start to consider what the solutions are. And the solutions, you know, in my mind, are more Aboriginal representation across the board, actually listening to Indigenous academics and Indigenous knowledge holders, and not just Indigenous academics that have Western qualifications, but our traditional knowledge holders whose knowledges have been largely disrespected and ignored, I guess, for a long time. We need to listen to those people. We need to ensure that we take all of that into consideration, and then we come up with solutions that are meaningful and authentic and engage appropriately with the aspirations and the needs of Indigenous peoples. You know, we need to think outside the box as well with this. We can't it's not just about having a RAP.
A Reconciliation Action Plan, or RAP, provides a strategic framework to drive an organisation's contribution to the reconciliation movement.
It's about enacting anti-racist policy. It's about, you know, engaging deeply and meaningfully for the long term. And it's not a quick fix. This is not going to be something that happens in an election cycle or overnight. This is a long-term problem and it needs to be continuously maintained. You're not just going to flick a switch and we're going to suddenly become anti-racist. It's something that we then are going to have to work to maintain over the years. And, you know, hopefully my PhD can go some way to providing a solution that will enable us to build an evidence base to demonstrate where our policies are failing Indigenous peoples and how we can do better. And I think we also need to learn from international examples. You know, Canada have just implemented legislation they're going to implement the United Nations Declaration on the Rights of Indigenous Peoples domestically. You know, we endorsed UNDRIP in 2008. 2009, and we haven't done anything about it. So we need to sort of do that.
In 2025, the parties to the Closing the Gap agreement are going to meet and consider progress on Priority Reform 3. How do you reckon they're going to go? Are they on track? There's still a bunch of work to do. What do you want to see change?
I've not really seen any major discussions about how this one is going to play out. I was at the Lowitja conference this year, up in Cairns, and there was a lot of discussions about Priority Reform 4, which was about data governance, but very little discussion around Priority Reform 3. So I don't think the conversation in 2025 is going to be great unless we get a move on. I think we do have a really long way to go. As I said, I just don't think we have the language to discuss this properly. Like, people get bogged down in the idea that calling out institutional racism is calling individuals racist, or mentioning someone's privilege, or white privilege is attacking white people. But that's not what calling out institutional racism is. It's about looking at how the structures and systems and processes have been undermining Indigenous people. And if we can make this work for Indigenous people, we can make it work better for a raft of other community groups. If we can make our health system safe for Indigenous people, we can make it safe for migrants, for refugees, for members of the LGBTQI+ community. Like, we can do better across the board. I'm focused on this area because that is, my positionality. Like, I am an Aboriginal woman. I worry about my daughter. I have a 5-year-old. I worry about her, identifying as an Aboriginal person on a form in hospital and not getting the treatment she needs. And, that is terrifying as a mother. I don't want that to be my concern. So that's why I'm focused on Indigenous people, but we can do better for a raft of other people as well.
As a policy specialist, you would have really different answers to GPs or epidemiologists. But so how do you think the closing the gap outcome of long and healthy lives can be achieved?
I can tell you what I don't think it will be. It's not going to be cultural awareness training or Aboriginal artwork in hospitals. While artwork is pretty and cultural awareness training is really important, it won't change the fundamental issues with our system. It is Priority Reform 3. Like, I think Priority Reform 3 is an absolute game changer. If we can change the conversation, we can identify and talk about the system as being the problem and not the Aboriginal people that are trying to use this system, then we can start to look at that closing the gap target 1 and start to address that discrepancy in life expectancy. We need to think outside the box when it comes to health service delivery and funding. We need to support the ACCHOs to do the work that they're doing. They do an amazing job. We need more support for preventative care and whole of community care rather than looking at people as a series of illnesses and body parts. And we need to focus on wellness at an individual, a family, and a community level. And as I said, we need to learn from international experience. Like, I'm looking at this case study of the National Aboriginal and Torres Strait Islander Health Authority. In British Columbia in Canada, they actually established one back in 2011. They established the First Nations Health Authority. And New Zealand just established the Maori Health Authority last year. So, we need to look at what those organisations have done, whether there's the capacity for us to, use that as a blueprint. But we also need to look at, can we expand the role of NACCHO? Like, did NACCHO have a place in the hospital setting, or are we asking too much of an organisation that was embedded in the primary care system? Priority Reform 3 is where I'm putting all my chips, and hopefully we can address that. And then I think if we can transform government agencies, the rest of it kind of becomes easy, right? Like, this is the wicked problem. And then the rest of the problems, if we can address the one wicked problem, the rest of them won't look so hard.
Well, Natalie Bryant, I'm very glad you're not another lawyer. I'm very glad you didn't stick it out in that legal degree at ANU. I'm glad you switched tracks into health policy. I cannot wait to see the impact of your PhD. And I thank you very much for all of the research you're doing, for challenging the norms and for finding better solutions. And I thank you for joining us here on Listen, Learn, Respect.
Thank you.
You can follow Listen, Learn, Respect in your favourite podcast app so you don't miss an episode. On behalf of the National Apology Foundation, thanks for joining us.